national and local perspectives of the impact of COVID-19 on older adults. We have a very distinguished panel prepared for you this afternoon. Each speaker is going to speak for 15 minutes, and we will have time for 30 minutes approximately of question and answers following their conversation. I understand that you can put your questions in the chat. We do have a list of questions already, and I'm hoping that they will cover all of the topics that you have for these individual speakers. And our first speaker right now that's up is Dr. Andrea Foebel from the Canadian Institute of Health Information, or CIHI as we like to call it here in Canada. So welcome, Andrea. Looking forward to your presentation.
Great. Hi, thanks for that introduction, Nicola. I'm just going to get my slides up. I hope that's okay.
That looks fine. Yeah, that looks good.
Okay. Oops, go back. So thanks, everybody. I'm Andrea Fobel. I'm a UW alumni and very happy to be back contributing in this way. I've been with CIHI for 4 years, and I graduated as one of the first PhDs in the Aging, Health, and Wellbeing program 10 years ago now. So I did some work with Inter-I in between. My talk today is about that pan-Canadian impact of COVID-19 on Canada's health systems. I'm going to be looking through some of the information that CIHI has put out over the past year. Land acknowledgement that at CIHI we're working towards better health for all Canadians, and we're mindful that we live on the traditional territories of and work with First Nations, Inuit, and Métis in a respectful way. For those of you not familiar with CIHI, this is our Ottawa office, and we are an independent, not-for-profit organization that essentially provides really essential information on Canada's healthcare system. I think most of you can relate that this might be what your work from home has looked like for the last year or so, whatever your situation is. I know it's been a little bit more of a juggle, so I'm looking forward to some days back in the office soon. A little bit of background, really the pandemic has thrust the availability of credible and timely data at the core of many conversations and decisions about COVID-19. How CIHI has played a role is we've really been a key partner in this response in terms of collecting and providing data and supporting all levels of government through modeling, standards, resources, analysis, and expertise. So I'll focus on some of the evidence and sort of analysis we've put together. We have a COVID-19 resources page, so if you visit CIHI.ca, it's very easy to find. It's updated frequently, and what you'll find is sort of a list of resources that you can either access through these boxes on the right side of the screen, or there's sort of a drop-down list that I've shown below that logo there. The information in terms of these resources is focused around things like data collection and coding. I'm not going to talk about those today, but there's been a lot of work with WHO to sort of ensure that some of those codes are integrated into our information systems. I am going to focus on our data and information, that second box. One of these pieces is a report called The Impact of COVID-19 on Canada's Healthcare Systems. That was released in November and is going to be updated. That was my team that led that work. So I'll talk about some of our key findings. And then there's sort of a vetted list of external COVID resources that people might find helpful in that last box. I'll focus here for the rest of my presentation. We have an intervention scan and timeline as part of those sort of resources. So if you haven't already been to it, I would encourage you to look at it. It's being updated sort of fairly regularly. And it's an interactive tool where you can choose the jurisdiction as well as a time frame and the type of intervention you're interested in. So it could be things like case management, closing and openings of different kinds of services, or states of emergency. And then you can go in and click on those little bubbles on the timeline to see what the intervention was at that time. So it's a helpful resource, I think. So highlights seems to be the wrong word, given that we're discussing information as a result of the pandemic, but I will just draw our attention to two parts. of CIHI data that's come out over the past 2 years. So the first is this impact of COVID-19 on the healthcare system work, and the second is a little bit of a consolidation of some of the information we've put into that long-term care information space. So in terms of the impact of COVID on Canada's healthcare system, this piece of work was fairly comprehensive. It involved a lot of data sets, focused on different sectors of the healthcare system, and it was published as web stories, so maybe not our usual type of content, but a more digestible format. There's good infographics in there. And then as you kind of scroll to the bottom of each of these stories, there is a link to fairly substantive data tables. So most of the information that you might be interested in can be found in those tables. I'll go through some of this. So in terms of key findings, or that overview story, there was three things we noticed when we did this work. One, the healthcare system transformed, and it transformed quickly. So as an example, virtual care, the tools for virtual care have been in place for a long time. Uptake had been lagging, and then sort of last March hit. So just the statistic I've included here is that 52% of patient visits, psychotherapy, and consults with other physicians were done virtually by April of 2020. So very, very quick. The second key message here was that, and this was maybe our most surprising finding, people really changed their behavior in terms of how they accessed the healthcare system. Maybe to a degree that I don't think the system planners were expecting. So as an example, there were 50% fewer visits to emergency departments in Canada in April of last year compared to 2019. So I'll pause and say that for this piece of work, we compared a lot of the statistics and volumes that you're seeing. We compared those volumes to volumes in that previous non-pandemic year of 2019. The third story is on unintended consequences. So a lot of things happened across the healthcare system to prepare for a surge of patients in inpatient care, to protect sort of that health aspect of individuals, and really those other unintended consequences of this work are going to be huge. So as an example here, we've just outlined that there was a 22% decline in that screening assessment for home care in April 2020. Could have been driven by less demand, but it also could be that people who needed home care were not able to access new service. We're going to be doing a lot more work on unintended consequences. I know there's a lot of interest in that. I'll touch on that briefly at the end. So now I'll get into a little bit of the key findings from each of the sectors. So I'll focus on the ED, on inpatient, and on home care. So the key finding for emergency departments is that the volumes really significantly declined in terms of number of visits compared to 2019. What you can see here, and this is sort of consistent across a lot of the measures we looked at, the major decline is sort of around that March-April mark, and then you do start to see some recovery by June. I'll just note that June recovery is not to the level that it was pre-pandemic, or even sort of that February level that we've included for reference. What I haven't included, but what I'll speak to, is that this was fairly consistent across age groups with some notable exceptions. So it actually was younger people, so children, who had the most reduced number of visits. For older adults in April, so again, everybody saw the same major decline in that April month. Older adults 65 and older and 85 and older had sort of a 45 to a 48% decline in number of visits. And that overall number for that whole wave one period was about a 30% decline in visits for older adults. If we look now to the inpatient sector, the big driver for a reduction in hospital admissions was canceled surgeries. So our estimate for that wave one period of March to June is that across the country, 335,000 surgeries were canceled. So what you can see here in the green line, that's surgical cancellations, and potentially a little bit of a bump to kind of prepare for what was coming. And the purple line is showing the corresponding drop in inpatient occupancy. Again, here for older adults, the drops were not as substantial or not as steep as that purple line is showing. So if we think about 65 to 84-year-olds, the overall decline was about a 20% decline from April to June, and the peak dip was about 40%. So sort of mirroring that purple line. I haven't included the ICU information here, but the ICU data mirrors this, except that I would say that there was not as steep of a decline. So that decline wasn't at the 40% level, and there was a quicker recovery. And again, for that ICU population, it wasn't seniors who were the most affected. It was actually the age 0 to 4 group, so the youngest children. If we switch to the home care setting, there's a couple of, I would encourage you to go to these stories if this is of interest to you, because there's a couple of key findings I won't touch on. If we look at overall assessments, including screening and full assessments in the community and hospital setting, what you can see is there's sort of a decline in all assessments with the exception of that hospital environment in March, potentially trying to sort of clear beds and get people into home care. And there's a sort of larger drop and a pretty significant drop in those community assessments. We did look at whether these were full or screener assessments, and just, there's quite a substantial difference in the volume of each type of those assessments, but we do know that there was more of a decline in full assessments. So people weren't doing the regular assessment. There was a little bit of a decline in those screening assessments as well, but that had sort of come up a little bit more by June. Haven't included it here, but there's a virtual care component to this health system work and to this home care piece. So what we saw was actually for in hospital, when we think of the RIE contact assessment, that screening piece, 70% of those were being done by phone in June. So another shift in sort of the way we're assessing patients and looking at care. I'll switch gears now to the long-term care perspective, and this is just a snapshot of CIHI's report on international comparisons that came out in June. So if we look to a comparison of 17 OECD countries, Canada had one of the lowest mortality rates overall, not one of the lowest, but it was lower than the OECD average. The second piece, that second statistic, though, is a little bit more humbling. So we did have the highest proportion of deaths due to COVID in long-term care. So of those infected in long-term care, many more died in Canada than in kind of that OECD group of countries. A little bit more updated information here, and the source here is from the National Institute on Aging. We had worked with Samir Sinhan Group as part of a report that's going to come out next week, but just in terms of, here's the numbers of deaths in long-term care across the Canadian jurisdiction. So more than 1,000 facilities had been impacted as of October, affecting more than 7,000 residents. There's a little note there too on the healthcare workforce, and I've got another slide on that as well. So there was a lot of information that people wanted given what was happening in long-term care during COVID. So this was an infographic compiled just to show the number of long-term care homes across the country and the ownership of those homes. On health workforce, this has been updated already once, and more updates are coming. But what you can see here is as of January, here's the statistics on cases and deaths among healthcare workers in Canada.
Andrea, 1 minute. Okay, 1 minute warning.
Perfect.
Thank you.
Yep. So I'll go quicker over here, but we did contribute some work to Ontario's Long-Term Care Commission, and really designed to answer some questions on what kind of characteristics were associated with worse outcomes. What this meant was there was a survey commissioned, and CIHI got sort of that data and combined it with our CCRS data to look at what was associated with some of these outcomes. So things associated with the likelihood of an outbreak was being a larger chain of homes, having more residents, and being in a public health unit with more COVID. things associated with a more severe outbreak. We're having a shortage of PSWs or PSWs provided by an agency. That was also the key factors associated with that high severity or high resident mortality. I'd encourage you to look that up. It's all available publicly if that's of interest to you. That's in Ontario. And just to close, what's next for CIHI? So we've tried to fill information in this space, and we're trying to be thoughtful about how often this is updated. So there is a pandemic impact on long-term care coming out next week. There's updates on COVID hospitalizations and ED visits, as well as that intervention scan. There's 2 pieces of work coming out in May on unintended consequences, and the health system impact work will be updated in June and in December. Thank you very much. Looking forward to the panel and questions later.
Thank you very much, Dr. Fobel. That was very interesting. And for those of you, I forgot to introduce myself earlier. I'm Dr. Mercer, Medical Officer of Health and Public Health Physician. So everything she spoke about really resonates with me and sadly continued throughout the second wave as well as throughout the first. So I encourage you to go see CIHI reports, which are always excellent. Our next speaker that we have this afternoon is Dr. Jennifer Walker. She's the Canadian Research Chair on Indigenous Health through Laurentian University, and she is speaking us today on the impact of COVID-19 on Indigenous peoples. And welcome to the floor. We got your notes pages there, Jen.
I just need to change it. I'm always, you think I should be an expert at this point. How's this looking?
That looks good to me.
Okay, thank you so much. And it's really nice to be here. I want to acknowledge that I'm talking to you from the traditional territory of the Tsikmikshing Anishinaabeg Nation. But I'm Haudenosaunee from Southern Ontario, from 6 Nations of the Grand River. I grew up close to there, off reserve my whole life. And I'm going to talk a little bit about the impact of COVID-19 on Indigenous peoples. And, I'm going to talk about it in terms of these 3 things: rights, risks, and resilience. And I think that what's happened with Indigenous populations has been distinct from what's happened, the patterns of what's happened with other populations. But it's also, there's lots to learn, I think, from the different approaches. So as I mentioned, I'm going to talk about rights, risks, and resilience, but that flowed together the way it sounded, but I'm actually going to talk about risks first. So really, if we think about why we are so concerned near the beginning of the pandemic about COVID-19 risk in Indigenous populations, there's a lot of reasons to be sort of concerned about how fast the pandemic could impact Indigenous communities. So first, there's potentially increased risk of transmission. So there's lots of reasons why a communicable disease might travel more quickly in Indigenous populations, and many of those have to do with social determinants of health, which actually are grounded in Indigenous determinants of health, including the long-term impacts of colonization, intergenerational impacts of colonization. So there's in some communities a lack of clean water for washing. There's household crowding both on reserve and in cities, and an emphasis on intergenerational households. And the more we talk about households from a public health perspective and sticking to your household, the more it becomes clear that households have a different meaning actually in First Nations communities, where there may be people who are part of the same household but don't always sleep in the same house. So there's lots of communication around COVID-19 and then measures that have been challenged by different worldviews. And I think that's one thing that we've learned through the pandemic. In addition to increased risk of transmission, there's also increased risk for severe outcomes. So Indigenous populations Also, due to generations and intergenerational trauma, where there are higher rates of underlying chronic conditions that increase the severity of COVID-19 outcomes, in addition to differential access to healthcare resources. And so I just wanted to show you just a couple of things that sort of set a foundation for that have helped inform, in particular in Ontario, the Chiefs of Ontario, in terms of their response. The first was a study we did around age.
Jen, sorry to interrupt you, but there's a big gray box on the slides, and I'm not sure if you can change that. It's on your end.
Oh, is it this box?
Yes.
It's you.
Okay.
Okay, it was the little picture of you. Okay, thanks for letting me know. I really appreciate it. Okay, so what we did prior to the pandemic, just in time, sort of had results that talked about both the prevalence of frailty in First Nations communities, and also the prevalence of multimorbidity. So this is just some of the underlying information that helped to inform the pandemic when, you see this report that was November 2019, and we sort of had this information in time. So the numbers that are attached to these small stars are for the general Canadian population. If we look at the prevalence of frailty in 65 to 74-year-olds, it's about 16%, according to this definition that uses the Canadian Community Health Survey. And if you look at how similar that is to First Nations communities, the prevalence of frailty in First Nations communities in the same age group, it's not even similar. It's much more similar to populations that are 25 to 30 years younger than First Nations populations. So it helps to inform the fact that, we have to be looking at younger populations because this sort of confluence of underlying risk factors are happening at younger ages for First Nations populations. In a similar way, if we look at multimorbidity, and I'm showing this because I want to show you that it's the previous slide was frailty in First Nations communities in Ontario, and this shows that it actually, if we look at the number of people, the percentage of people who have multiple chronic conditions, that it's whether you live in a First Nation community or outside of a First Nations community, if you're a First Nations person, you're more likely to be living with multiple chronic conditions. So this underlying level of risk is high. So moving on to rights, if we think about the kind of responses that happen and the responsibility that First Nations, Métis Nations, that and Inuit have to respond on behalf of their communities. So I'm bringing us way back for a second to talk about rights, because what's fundamental to the response, the COVID response by Indigenous nations, is the right to self-determination. And the rights that are embodied in the United Nations Declarations on the Rights of Indigenous Peoples are the rights that that make it so that First Nations need their own data to be able to inform their pandemic response. First Nations need their own institutions to enact their COVID response, and they need to develop their own priorities and strategies and to administer programs. And so the role of other governments and institutions needs to be to support those initiatives and to support those communities. So an integral part of that is the availability of data. And I really appreciated Andrea's conversation around how important the data and the data flow and getting information is to understanding how to respond to COVID. And in terms of Indigenous nations, there is this cycle between building nations and building data. And that part of self-determination and sovereignty is nations governing data. So the governance of data is one really important part of it. But then using that data for governance is the other part of that cycle, a really important part of that cycle. And we saw how important this is during the pandemic. So to ground us just in the context where I mostly work and where I live is Ontario, and these are the 133 First Nations communities in Ontario. So this obviously doesn't include Métis Nations, and this is the location of the First Nation community. So for example, you know, the First Nation community that I'm a member of, I don't actually live there, but that's where my First Nation community is, though I live in Sudbury. And so each one of these First Nations had to develop their response and protect those knowledge keepers, those language speakers, those elders in the community, and find ways that are culturally grounded to protect. And you might remember headlines from early in the pandemic where enacting that sovereignty meant actual closures. Like people could not enter First Nation communities. And that persisted for many communities for months. And actually, you know, had a lot of impacts in the community in terms of, you know, the availability of goods, medications, all sorts of things, but also how safe and how few on-reserve outbreaks we had in the first wave of this pandemic. I'm going to just move quickly through this, but just to say that part of that data governance process has that has been established in Ontario has enabled us to move quickly on being able to show results and get results to First Nations leadership quickly. So early in the pandemic, we were doing like imaginary models. We were like, people need information. And we were doing these models that were not informed by data, that were sort of worst case scenarios to help try and inform. But over time, not very long into the pandemic, we're able to, at ICS, where we hold health services data for all of Ontario in a linkable way, we were able to unlock that data and start flowing information to First Nations leadership, to individual First Nations communities, to the Métis Nation of Ontario. In a similar way, other regions were able to do this. So I have a link there to an example daily report for Manitoba First Nations. But what we'll see, what I'm showing you here is the actual tracking of First Nations people, whether they live on or off reserve in Ontario, and the positive results for COVID-19 over time. You can see almost no first wave. Okay, so in these months that Andrea was just talking about, we had so few cases. This is where we had those closures. This is where those roads were closed, and they were like, we need to protect our older people. You can see what's happened in the second wave, and you know, it's the numbers have really changed. The narrative has changed. Our whole experience has changed. But you know, living in Sudbury, I can see that our narrative in Northern Ontario has changed overall. So it's one where, you know, it was sort of localized and really has spread throughout the province. The positivity rate for First Nations has also increased. So this is the rate for this is the positivity rate for First Nations in the bold line, and then the dashed line is for all of Ontario. So it generally follows the same pattern, but you can see that we didn't have that really high positivity rate at first, and we're getting that higher positivity rate coming on now. One of the things I want.
Sorry, Jen, 1 minute notice, sorry.
Yeah, thanks. Oh, wow. My thing says I still have 3, so I'm paced wrong. Okay, so I'm gonna just a couple of more points. One is what I'm calling the pandemic pylon, which is to say that we're not talking about a brand new situation without any underlying crises already. And so just to say that in all of my interactions with elders and older adults, in all of the research projects that I work on, mental health, the mental health of youth, the opioid crises in First Nations communities is top of mind, and is people have lost more people to opioids than they have to COVID, and it's during the period of COVID-19, and it's really crisis. The other thing that I want to say is that vaccination is rolling out, but there are considerations around colonization and context there as well, in terms of building trust around the vaccines, building trust around the process for everyone. There's a resource I'll just point you to without talking too much about it, given my time. And that is this resource that's a story-based methodology to tell the stories from across the country of COVID-19 and Indigenous populations. And really just it emphasizes how important a relational worldview is and that resilience. The last point I want to make is just that sovereignty has been foundational, relationships are key, and where those data relationships were strong, information could flow much more easily to support that decision-making and the sovereignty of nations during the pandemic. Thank you, Yahweh.
Thank you very much, Dr. Walker. Very, very interesting. I was looking forward to that. We now need to move along. I'm sorry for the time constraints. Our next speaker today is Dr. Carrie McAiney from the Schlegel Research Chair in Dementia. Welcome, Dr. McAiney, to the floor.
Great, thank you very much. Is that okay? Can you see the slides all right?
I can also see your notes pages as well. So I don't know if you can see me, Carrie, but if you see me put my fingers up, that's 2 minutes. Okay.
Okay, thank you very much. So thank you everyone for participating in today's session and for the opportunity to be part of this. As mentioned, I will be looking at the impact of COVID-19 on people living with dementia and family care partners. So as we all know too well, COVID has really impacted all aspects of our life, from our work and our school to seeing our friends and families and the types of activities that we are or are not able to do. So essentially it's affected everything and everyone, and that includes people living with dementia. So just to make sure everybody is on the same page, I'll give some background information about dementia. So dementia is not a single condition. It's actually a term that refers to a group of conditions that share a common set of characteristics, such as impairments in memory and judgment and reasoning. And there are a number of different types of dementia. Alzheimer's is the most common, but we've also got vascular, frontotemporal, Lewy body, and others. And you can also have more than one type of dementia, which is called mixed dementias. In Canada, we have over 500,000 people living with dementia, and there's about 25,000 new cases diagnosed each year. The majority of people live in the community, and when we look at the long-term care sector, the proportion of people living with dementia is over 70%, but that can vary from home to home, so some homes would have a much higher percentage. So other than the prevalence of dementia, why is it that we might be interested in looking at dementia in the context of COVID? We know from the time a diagnosis of dementia happens that people often experience isolation. So they often have friends and family that may move away and not have as many interactions with them. There can be changes to a person's role in terms of their work life or at home, or even in other organizations or activities that they might do. And there's often fewer opportunities for them to participate. For some people, there comes a time when they need additional supports and need to move into a long-term care home. And once again, there's often isolation that is experienced. So people may have additional loss of contact with family and friends. They also lose that familiar environment and the routines that they've become accustomed to. So isolation and that experience can be quite common for people living with dementia and also for their care partners, because there too, their roles are changing because of the additional responsibilities that they take on. And they may also have friends and family that move away. So if we think of that common experience of isolation among these groups, and we think about how much that might be compounded by COVID, it really speaks to why we would want to look at this particular issue. So what I'm going to do today is just provide a few highlights from a study that we're currently conducting on COVID and dementia. And specifically what we're doing is looking at how COVID has impacted the daily lives and social connections of people living with dementia in the community, and the family and friend care partners of people with dementia in the community and in long-term care and retirement settings. Unfortunately, we're not able to conduct research right now with people living in long-term care. But in addition to understanding how COVID has impacted them, we were also interested in seeing the types of strategies they've been using to support their well-being and to be connected with others. So what we did was conduct surveys and interviews with people with dementia and care partners. And so I'll just share a few highlights from that data. Just one thing to note, our survey responses for people living with dementia was low, so we do have to be cautious about drawing any conclusions. So one of the things that we wanted to do in the survey was to compare how things were for individuals during the pandemic compared with before. So we were interested in looking at some of their health behaviors. And we asked individuals to indicate, so this is self-reported data, to indicate whether they were engaging in these behaviors more often than they did before COVID, less often than they did, or were they engaging in them less often during COVID, more often during COVID, or about the same? So if you look to particularly the right-hand side of the screen, probably not surprising that in all three groups, people indicate that they are connecting with their friends less often, and also reductions in connections with families. The other thing, though, that sticks out here is that it's the care partners of people with dementia in the community that seem to be engaging in these health behaviors less often. And it's, again, probably not surprising. And this was discussed a little bit earlier in the international panel. But for people living in the community, the individuals with dementia in the community, a lot of times their supports, services, activities have either been canceled or have moved online. And so the care partners have had to really step in to provide some additional supports, or even just to provide, socialization and engagement and stimulation. So it's probably not all that surprising that they then have less time for themselves and doing some of these behaviors that they might have usually done. So despite maybe not always being able to engage in some of these health behaviors, the data that we received indicated that people were able to use different strategies to try and enhance their well-being. And so this is just a bit of a snapshot. We actually got quite a lot of data related to strategies that people were using. And here you can see that there are both tech-related strategies and non-tech-related strategies. And that was, and it goes across all of the three groups that we were interested in. One of the other things that we wanted to do in the survey was to look at people's experiences or feelings during COVID. And so what this chart demonstrates is the percentage of people that reported feeling more isolated, feeling more worried or anxious, for the care partners feeling more strain, and for all groups, to those that were reporting that their quality of life was lower than it was prior to COVID. So again, you can see really high rates sort of across all groups, but once again, it's the care partners of people living with dementia in the community that are really showing the level of isolation and worry and strain that they are experiencing. So as mentioned, we also conducted in-depth qualitative interviews, and the goal of those interviews was to really try to understand in a deeper way what the experiences were like for people living with dementia and their care partners. So on the next couple of slides, I'm going to share some quotes that describe some of the challenges that people, the partners, people with dementia and the care partners were shared with us in those interviews. So first, a couple of examples from care partners of people with dementia in the community. So they are doing virtual meetings, and I get him connected to all of that. He can't do any of it on his own. So everything that gets done, I have to facilitate. And I do it to keep him mentally engaged. But there's no respite for me, ever. Another care partner. I feel I'm losing my mind, my ability to think. I'm more irritable. I do not like the person that I've become. So like we saw in the survey data, these quotes really demonstrate the stress and the strain that the care partners of people with dementia in the community are experiencing during COVID. A few examples from care partners of people with dementia in long-term care or retirement. So I became the main caregiver, and so that was taken away from me, and I felt like I was doing something for her, for my mother. It gave me a sense of purpose and helping, and then that was kind of taken away, and then we couldn't see her. In April, my father passed away. He basically stopped eating. I think he was very lonely, and though he couldn't express it, he very much missed the regular social interaction. He couldn't communicate through a window visit or by phone, and I wasn't permitted to visit. And so many of you probably know, especially in the first wave, care partners of people in long-term care were not allowed to go in and visit. And so these quotes really demonstrate how difficult that was for the family members not to be able to see their loved ones in long-term care. And then a couple of challenges identified by people living with dementia. I personally will not go out of the house because I think if I get COVID and it affects the O2 level in my blood, what is that actually going to do to an already damaged brain? So speaking to the fear of contracting COVID. And the thing that I think is the most challenging to me, I miss the most, I'm 71 years old and I'm at the age of starting to lose a lot of my old friends. And we're not allowed to go to funerals and don't really get to say goodbye. And that's probably been the worst thing. So really, again, showing that the isolation and the difficulty in not being able to see friends and to honor people that have passed on. Despite these challenges, one of the clear things that came out in the interviews that we conducted was the resilience of people living with dementia and care partners. So in the next couple of slides, I'm going to share a few quotes that demonstrate this resilience. So first, for care partners of people living with dementia in the community. I am more appreciative of the time I spend with Mom. I'm trying to accept the way things are rather than being upset about things I cannot change. And also, well, use an analogy. I've said this lots of times. This whole journey in life with dementia is like a roller coaster. And I can either grab on tight and scream and hate every minute of it, or I can throw my hair and hands up in the air and laugh and try to find the joy in it. I love that quote. Now from care partners of people living with dementia in long-term care and retirement. So some of the groups I was talking with wanted to do Zoom and I said, no, I can't do that. I just didn't do that. Well, now I was forced into it. And you know, I can do it. So I learned, and I like it actually, because it's nice to talk with people face to face. And another, I learned to welcome what does come my way and truly appreciate my friends. So it's seeing this resilience in terms of being able to learn new things and to take perspective on what's happening. And then finally, an example from a person living with dementia. So even though people tend to say, well, we're isolated and we can't do anything, you can still do things. You just have to decide to do things differently. People with dementia have learned how to be adaptable and how to do things differently. So maybe for us, this is the silver lining. We're getting through it easier than other people. Just a few concluding comments. As others have discussed today, and it's the same is true for people living with dementia and care partners, COVID has had a significant impact on their health and their well-being. But I think it's important to recognize and acknowledge and celebrate that these individuals are also very resilient. And so we need to remember that each person is unique, both in terms of their experience of dementia, but also their response to COVID. And that whenever we're thinking about how do we support individuals, we think about that in an individualized and tailored way. Just wanted to acknowledge the support from our team of researchers, the funding support from the Network for Aging Research. Also, thanks to Trevor Bain for his technical support earlier this week. And then finally, a sincere thanks to the people living with dementia and care partners who agreed to participate in this research and share their insights. Thank you.
And thank you, Dr. McAiney. Those quotes were very inspirational, and I shall remember some of them as I move through the remainder of my week. Our next speaker today is Dr. Veronique Boskart. She is the Executive Dean of the School of Health and Life Sciences at Conestoga College, and I'm looking forward to your presentation on working through COVID-19 pandemic local experiences in healthcare and education. Welcome, Veronique.
Thank you, Dr. Mercer, and thank you for the committee for giving me the opportunity to present to you today. Just looking for a nod of heads to see if you can see my slides. Yes, great. So I want to acknowledge and recognize the people that I've had the great fortune to work with. Some of them are on this meeting. I'm housed at Conestoga College, and I am funded through a CIHI research chair funded by Schlegel Village RIA, Conestoga College and Point Click here, as well as SAT TENA. And so the work I will be presenting to you today is partially done as my role at Conestoga College, trying to work with the college through the pandemic crisis, but also as a registered nurse working in a long-term care home who went into a full outbreak. So in sharing some of the experiences in healthcare and education, it was a very interesting past year in that two different worlds came together. And so I think, and especially for the chair of the session, I do not need to show you any of these numbers, but just to remind you that I think a lot of healthcare providers and educators, decision makers in our region just really kept a very, very close eye on everything that was happening. For me, that is in the Waterloo region. And I really want to shout out a special thank you to public health. Without their guidance, support, and all of the data that they had to gather and test and track, it would have been very difficult to make decisions. It was difficult as it was, but thank you to public health for guiding us through a very stressful time and continue to guide us. So at Conestoga College, we are a large community college. We have about 40,000 students that come through our doors. So this came as, of course, an immediate stop to everything that we were doing. And so we adopted what we like to call the Swiss cheese model in trying to put different layers in place to protect all those that are in our campuses. And so the college has 7 different campuses. Some of them are actually within long-term care homes. So we really had to act rather swiftly to make sure that everybody was protected. So in realizing that none of these measures are 100% effective, we build in different approaches to this. And so together, we really wanted to protect the college community. In doing so, we realize all too well that our college students are in and out their local communities. And so we really wanted to make sure we kept everybody safe. Right away, we were faced with an interesting challenge in that we work with different cohorts of people. We work with people straight out of high school. We work with people that come for a second career program. We work with people that have existing jobs, often within healthcare settings or within larger environments. And so we really need to diversify to see what it was that we needed to do for those different groups. We chose to focus on what we could control within the college environments, and then realized that COVID fatigue was something that set in quite rapidly. Our college students and our employees really struggled with the fact that everything needed to move online. And some of those programs don't really lend themselves well to online education, especially the programs that I oversee, which are the health sciences programs. We established kind of a main security dashboard in which people could report concerns. And then we invested a lot to support teams, and that included trying to figure out labs and clinical placements for our nursing, PSW, and other healthcare students. So we prioritized health sciences programs because these became very important players into the healthcare workforce. As a matter of fact, the entire campus was shut down, and health sciences took over both the rec center and every possible space in the campus to really spread out as much as we could. We donated close to $2 million of PPE and every possible accessory in our SIM programs to our local hospitals and nursing homes to make sure that they could continue to work. And a lot of those supplies have started to trickle back in, which is important for us because we have to start teaching. We developed a separate screening strategy for those students that are doing clinical or have jobs within long-term care and acute care settings or within the community to make sure that we kind of kept them separate from everybody else within our campuses. And then obviously we practiced good and strong IPAC measures. We divided the entire campus in different zones related to risk. So, for example, nursing students that were working as PSWs and long-term care homes were not getting in contact with anybody else within that same nursing class. So as you can imagine, it was quite a reorganization of what we normally do. We then developed protocols for case, contact, symptomatic, and any accommodations. We have a very large international student group, and so we really had to find accommodations for a lot of them because they could not continue to stay in their current accommodations, but they also could not come and attend class. And so we reviewed a lot of the current policies that were in place. And then we really had to do a lot of work with programs outside of our health sciences programs to explain what a positive result means and who we are sharing that information with, which was a steep learning curve. And then obviously for any positive case, especially in our healthcare science students that are working within the healthcare environments, there was consultation with public health and a strong awareness. I also want to point out that up to 60% of our faculty within the School of Health and Life Sciences chose to support their local communities or hospitals or long-term care homes with clinical work. So it was a real readjustment to our teaching approach. I'm very happy to tell you that we were able to graduate every one of our healthcare students, including PSW and nursing, that was in the program, and that we attracted a very strong new cohort going through the program despite all of the limitations that we have. So we were able to provide our community with the output that we normally provide every year. So we're very proud of that. And so we hope that they are your colleagues today. So then moving from that educational environment into the healthcare world, obviously there was a clear lack, I think, in my colleagues already indicated that there was some vulnerable population not get that early attention and they were hardest hit. I am going to focus for the second part of my talk on the long-term care and retirement living environment because that's where my clinical work is and all the adjustments that needed to happen there from a clinical care perspective. But so obviously we're all very familiar right now with all the outbreak protocols and the limited visits or no visits policies that were in place, the screening protocols. And then a very big change early on, April 14th last year, during the pandemic, was the limiting work to a single long-term care home or retirement environment that had a tremendous impact on the current workforce staffing. It was placed it was the right thing to do, but it had an immediate impact on the staffing, the shortness of staffing, because most staff working in long-term care and retirement has more than one work environment, and so they had to choose. And so that was a reduction of up to 40% of current staffing in any existing home. And then the regulations in place for essential caregivers. So having worked through, and I know this is a safe environment, I can tell you that after 25 years in nursing, the work I've done as a nurse within a long-term care in a full COVID outbreak was probably the hardest thing I've ever done in my life. First of all, the resident care. It was incredibly difficult to provide resident care while masked and gowned and having every possible layer on, knowing that there's a lot more that can be done, but you don't have the time to do that. And so my colleagues already indicated that resident care suffered on more than one level. And it is very difficult to observe and watch that and to do whatever you can with the resources that you have. On top of that, residents' emotional and social well-being suffered. And I know I think my colleague Carrie spoke to that very eloquently. It was very difficult to see that rolling out and then really not knowing when the end of that was going to come out. On top of that, families and essential care partners, and those that are incredibly important, suffer tremendously. I am not the only nurse or caregiver who had to walk across several cars on the parking lot of my nursing home where you had family members waiting to talk to you in order to get at least an update of what was happening. And so not every family and care partner has the capability or the resources to set up technological support in order to connect with their loved one on the inside. So then moving on beyond that, the staff's capacity to meet needs was severely impacted. I think all nursing home directors and managers did the absolute best what they could do, but there just was not enough staff, especially after the single site directive, to meet the needs that were out there. And in addition to that, the mental health of those providing care under difficult circumstances has definitely been jeopardized. And I think we're definitely seeing the fallout of that as well. Then moving one level higher, I think at an organizational level, we see the same stress and moral struggles, because at an organizational level, there is only that much you can do to redirect and maintain a level of care workforce while meeting all the regulatory demands. And so that constant juggle has definitely taken a toll, and it's not done yet. And then at a regional level, something that was very apparent is the regional delays of transitions of older people within acute care or ALC beds back into long-term care homes has been so severely delayed that now there is a really big backlog that has now started to be resolved with what we see right now, or at least in the home that I work in, is that you do see people coming in that are so jeopardized and have such severe decline because they stayed very much longer in an environment that could not really meet their care needs. And then lastly, I wanted to quickly talk about the stigmatization of the sector, especially in long-term care, has not done any favors. And the staff turnover was high to begin with, 40%. And there is some early reports out there that that probably is now 60%. And I myself has, of the four nurses that I regularly work with, two have taken early retirement because they just could not do it anymore. And I think that stigmatization will have a profound effect for the next 5 to 10 years. And then obviously the government's response time to a crisis, despite all of the difficult decisions that had to be made, had a very big impact on what happened in long-term care. So having said all of that at a local level, lots of good work was done throughout all of this. And I think one report I wanted to highlight is the Restoring Trust report that had highlighted recommendations early on during the pandemic to really look at staffing. And so I'm going to spend the remaining couple of minutes on that. I'll make the link available, but there is some very strong recommendations that are not new, but are very easy to follow if one wanted to really have an impact on the long-term care retirement living sector. I think none of them are new on this list, but the emphasis on strong PPE and training and infection control is important, and then using technology to fully engage residents. And then from a workforce recommendation, one thing that has finally been pushed through is the national staffing standard and staff mix to legislate minimum hours, at least in Ontario, for 4 hours of nursing and personal care. Right now, we are not even at half of that in our long-term care environments. To then look at PPE and protocols for infection control, and to implement appropriate pay and sick leave. And I know that is still a very hot political item that is still not resolved and ought to be resolved in order to move forward. And then lastly, I think that providing mental health supports for those that have been in these environments, have worked under tremendous stress, is a must, or we will lose more staff in these environments. So lots of recommendations out there. The last one will reflect back to Andrea's first presentation. We do need mandatory data collections to really look at quality care of life, but also at the work and life for residents, families, and staff in these environments. So In closing, I think systematic issues have been uncovered. They're not new, but they're definitely highlighted. Recommendations are in place. It's up to us now to move them forward and to get the political attention and goodwill to really make a difference in these environments and to keep our residents safe. Thank you.
And thank you, Dr. Boscart, for a very stimulating presentation. And I'm sure there might be a few questions in regard to that afterwards. Our last but not least and final speaker is Dr. Vivek Gwell, who I've known for quite a number of years now, and he has many titles. But I think the title that's probably most relevant is he is the President and Vice Chancellor Designate for the University of Waterloo, so our incoming president. So welcome, Dr. Gwell, to the floor. Oh, Vivek, you're on mute. Sorry. Vivek, you're still, Dr. Well, you're still on mute, so I don't know if you can.
There.
There.
Sorry.
That's perfect. Great. Yeah, thanks.
I have trouble getting my mouse back. Okay, can you see my slides now?
Yes, it looks perfect, and we can hear you.
Okay, so sorry about that. And so I just hoping that in this last presentation, I'll be able to bring several of the themes that have already been highlighted together. I'm going to focus a little bit at a higher level on how science and policy have been intersecting and how decisions have been made or perhaps not made. And some of our speakers have already hinted at that. The picture in my title slide here, some of you may be familiar with it if you went to public health at University of Toronto, is the old School of Hygiene building, the Fitzgerald building. And I put it up in these talks to remind ourselves that we've been there before in this country. And this was part of the investments made after the 1918 influenza pandemic in public health in the country and research capacity, the Connaught Labs. We were one of the global manufacturers of vaccines. And so one of the lessons we have to think about is what happened. How did we go from being a global leader in areas of public health and infectious diseases to where we found ourselves at the time of SARS or H1N1 or now with COVID-19. We've already had quite a bit of data presented, and this might be a little busy for you, but this is basically showing hospitalizations, ICU admissions, ventilation, and deaths by age group. And the darkest blue bars are older adults over the age of 59. And you can see that regardless of the metric, the older adults had the greatest number of hospitalizations as well as deaths, but that the proportion is much higher for deaths. And in fact, we go from, if we had cases on this, from about 20% of the cases for people 60 and up, almost 70 to 80% of the hospitalizations and over 95% of the deaths. And the other thing that is unfortunate about this slide, and it's already been hinted at, if we look at the first wave and the second wave, the number of deaths in this older population remains the same proportion. And we knew, and Veronique highlighted some of those recommendations, we knew at the end of the first wave, or even in the midst of the first wave, what we needed to do to avoid that same situation in the second or third wave. And we failed to act. This shows the setting of outbreaks, and the green bars are long-term care and retirement residences. You can see from May to the fall and winter, remained the site of the largest number of outbreaks in absolute numbers, and other congregate living settings as well. But you just look at the relative proportions of the outbreaks. And this shows the total number of cases and total number of deaths. And so these are the outbreak-related deaths in long-term care and retirement residences, representing about 12,300. out of, I think at the time that I pulled this, it was about 2,200 deaths in Canada. If we add in the deaths in the people in the older age population living outside of long-term care, again, as I said, that represents the vast majority of all the deaths in this country. Veronique already referred to this report from the Royal Society of Canada. What I would just emphasize is something that she said. None of these recommendations are new. And there's, in fact, there was a paper or article that accompanied this in the Globe and Mail, which highlighted the decades of reports on long-term care and more generally on aging and how we can best support people as they age that have gathered dust on the shelves. And the same can apply for public health, for other areas that we've seen gaps in our response. And so for me, the most important lesson is that we have to keep going back and asking why those recommendations in the past were not acted on, why we failed to act on recommendations between the first and second wave. And again, it's not for a lack of knowledge about what works, what doesn't work. In Andrea's presentation, she highlighted some of the differences across the country. And in this paper at CIHI in the fall, they compared Ontario and British Columbia. And you can see the difference in the infection rate as well as the mortality rate for people living in long-term care facilities. It's actually 4 times higher in Ontario. And we know there are things related to characteristics of how things are organized, how services are delivered, as well as how the timeliness of some of the decisions that government and public health made. But we need to look at what has happened across our jurisdictions and try to learn from these lessons as we move forward. So turning a little bit more broadly, it's a slide I've been using in some of the sessions I've been doing. There's a long list here. We obviously can't go through all of the things listed here, but just to highlight that these are societal trends, global trends that have been underway for many years. And again, earlier speakers have referred to this. So there's nothing new here. But what COVID-19 has really shown is how these have challenged our response or how they've affected different populations. And so we think about polarization of politics has affected how we've chosen to implement measures, how we can see the differences in the United States versus Canada, and the United States across states, but in Canada also across provincial jurisdictions, and even in Ontario across the public health units. And I'm sure Nicola can attest to that. And so, it's, not all of that is politics, but much of that can be driven by politics, whether it's at a local or regional level. Geopolitics, the impact on perceptions of the World Health Organization. Globalization, the impact on manufacturing, and we're seeing these issues right now with vaccine nationalism. We've already heard about Indigenous communities, but we also know not only were Indigenous communities affected by COVID-19 in very different ways, other racialized communities in our population have also had very different impacts. The labor market issue, Veronique referred to some of the labor issues within long-term care, but throughout society with the public health measures, we've seen those kinds of responses. A word about my last point. I often, when I'm asked, what's the greatest threat to the health of Canadians, I'll say the Constitution Act. Our response in Canada has very much been influenced or driven by the fact that we don't operate as a single national entity. We are a federation of provinces and territories, and every province has jurisdiction over health. The federal government has jurisdiction over the borders and certain aspects of the response. The regulation and approval of vaccines as an example. And so we need all levels of government working together. And this has been an ongoing challenge for us in Canada. We often hear the politicians saying that they are relying on the science, they're relying on their medical, public health, scientific experts. But we have to acknowledge that for many of the decisions that need to be made, the science is imperfect. The science may not be available. And that many of the decisions that have to be made are informed by science, but are not going to be solely based on science. And so I think at times we might also actually say our politicians try to hide behind the science or behind their public health experts so they don't have to make what can sometimes be very difficult decisions. And so I'll give some examples, but the science is something that we need to think about as a factor that goes into decisions, as opposed to be decisions are solely science-based. And a recent example of this that played out very prominently in the media was the recommendations about extending our dose interval up to 12 weeks between the first and second dose. And we had scientists, including our chief science advisor to the Prime Minister, Dr. Mona Nemer, very vocally opposed to that recommendation. And we had public health leaders such as Dr. Bonnie Henry in British Columbia eloquently defending the decision. And the key thing is this was really a policy recommendation given the circumstances we find ourselves in, and how do we maximize the benefit for the greatest number of people. And a simple way of thinking about it is if you have 2 doses of vaccine, that on their own, each dose the dose will be about 85% effective. If you give them together as a sequence, it's about 95% effective. If you have 2 grandparents who need the vaccine, do you give one of them the 2 doses at 95%, or do you give them each 1 dose at 85%? That's the kind of decision that public health leaders have to make. It's informed by the science, but it's not solely driven by immunology experiments, as an example. There's quite a bit that's been written about the biases that enter into decision-making. I don't have time to go through all of these, but happy to come back in discussion. But the key thing I'll emphasize is these biases have actually driven a lot of our decision-making, including explains why people were buying toilet paper last winter. The one thing that these biases really lead to or highlight is the difference between what I'll frame as the medical model of decision-making and a population health model. And I wrote this article about a year ago, and they used this picture to illustrate this. Everyone is familiar with Anthony Fauci, infectious disease specialist, head of the National Institute of Allergy and Infectious Diseases. Most people can't recognize the person on the right, Robert Redfield, who until the change of administration was the head of the Centers for Disease Control. We saw a lot more of Dr. Fauci than we did of Dr. Redfield. And to me, that speaks to what I refer to as the medicalization of the response and not taking as much of a population health or public health perspective. The other thing, just looking back in history, this is a quote from another Royal Society of Canada report on looking at past history. And, if you read this quotation, it could be talking, it just changed a few words, and like they refer to wards, we could talk about districts, they talk about servants for the higher income people, probably don't have as much of that these days. But really, this is describing what we've experienced with COVID-19, just as easily as it's describing 1918. Yet, if we think back to last March and April, we didn't actually talk very much about social determinants of health. And our response was driven by how many people in ICU, how many ventilators do we need to build, and much less attention until actually the kind of data that City of Toronto started to put out around where cases were happening, And to be perfectly blunt, the events of last summer, which drew attention to racism in our societies, really started to bring attention to what was happening in the population. And so when I talk about a population health perspective, I say we need to think obviously about COVID-19 and its consequences, but we also need to think about the broader consequences for the population of both the disease as well as the public health measures that we're implementing. And in terms of the older population, we've already heard quite eloquently some of the impacts we've seen on mental health, social connections, and so on. And I just, again, list some of the things here. And in the CIHI report, some of the health system consequences have been highlighted. I want to leave you with two things. One, this is from the Canadian Pandemic Influenza Plan. And I've been fascinated as I do these presentations, how many people are completely unaware there was a pandemic influenza plan, including people in government who are making decisions. And it has two goals which are meant to be treated equally: minimize serious illness and overall deaths, and minimize overall societal disruption. And that first goal is from all causes. So not just COVID-19 and its consequences, but looking across a full range of diseases, mental health. And the second goal looks at societal, schools, as well as the economy. And so what I think has really happened is particularly driven by what our political leaders tended to talk about early on, what the healthcare system leaders tended to focus in on. Our response has been driven primarily by the first part of the first goal, which is a focus on COVID-19 numbers. And we really have to come back and look at the much broader perspective. I want to close with a positive note. And probably the one thing that was done right for long-term care, I didn't see any disagreement about this, was prioritizing those populations for the vaccine. And as soon as we had our first doses starting in December, both the residents and the workers were to receive it. And the Ontario Science Table put this out a few weeks ago and showed basically what the impact of having rolled that out, the dotted line, is what would have happened if we hadn't had the vaccine rollout in terms of cases and what happened. And we now basically have brought those outbreaks under control. So it does show that once in a while we do get the decisions right, and we can have significant impact if we make those right decisions. Thanks for your attention.
And thank you, Dr. Gwell. You raised some incredibly important points. I'm just going to set the stage now for how we're going to handle the question and answer period. So I will be directing questions to individual panelists. However, please feel free to put your hand up if you would like to add to the conversation. I think it's more important that we have a dialogue. I have a number of questions that have been submitted, or some themes that have been submitted. But if you feel that you would like to add to a panelist's point, please feel free to put your hand up. So my first question will be directed to you, Dr. Fobel. What surprised you most as you look back over the past year with regard to the data, whether that's either Canadian or international, that you have reviewed? And going forward, what are you planning to follow most closely in the next few years?
A challenging question. I think from a national perspective, that behavior piece was something surprising. So the impact of the pandemic and everything that was going on in terms of how Canadians chose to access their system and chose to potentially decline or defer care. So one of the specific pieces that we know we don't have good data on is diagnostics. How much is missing? How many Canadians were affected by having something delayed because that process hadn't been started? Looking forward, I think there's going to be a lot of work on those so-called unintended consequences. So I'm going to be following that, recognizing that some of those are more immediate. So some of the mental health impacts at a population level versus some of those that are going to be long-term. So I think from a CIHI perspective, getting the data set up in a way that we can be able to track back to whether somebody had had a positive COVID test when vaccination happened. Those kinds of things are going to be important for those longer term unintended consequences.
Thank you very much. Dr. Gwell, is there anything that you thought was surprising in the data over the last year?
Just highlight one thing to build on that is when you look at the emergency room data, it was across all levels of acuity. So it wasn't just people with a cold or a stomachache not going to the emergency room when they didn't really need to go. It was people with strokes or heart attacks not going to the emergency room. And the same applies with some of the data, childhood immunizations, visits were deferred, all sorts of other preventive behaviors. And we won't see the consequences of that for months or even years after this. And so, as Andrea said, the unintended consequences are going to be with us for some time to come.
Anybody else want to comment before we move on? Next question is for Dr. Walker. You mentioned in your slide deck, you talked about specifically about building trust. And so as the vaccine rollout is progressing across Canada, Indigenous peoples have actually been prioritized into phase 1 in many areas. I'm wondering if you can speak to vaccine hesitancy amongst our Indigenous populations from the perspective of building trust and what barriers or approaches need to be considered as we optimize vaccine uptake.
Thanks. So I think there's a couple of layers of this, I think, actually, because there's an individual's choice and their trust in, and so that hesitancy and the building of trust among individuals. And then there's also the building of trust and the hesitancy that might be more collective. So anecdotally, I've heard of communities where the leadership has decided to be quiet about vaccines, to leave it up to individuals, but not to promote it just in case it's actually harmful, kind of thing, right? So that collective trust and the collective the building of that is probably just as, or maybe even more important. But a lot of the hesitancy came before the vaccine rollout, and then as the rollout has happened in some communities, it's been, there have been like high numbers, like high proportions of people are now, all the adults now vaccinated. It sort of, those stories started to roll, and then so I think it's really coming.
You might be on mute, Jen. Can you just check that you're not on mute?
I'm not on mute. Can you hear me? Did you hear anything
I
I
can
said?
hear. I can hear you now. There's just the last sentence. You might want to just back up a little tiny bit.
Okay, just the importance of relationships and sovereignty is what I wanted to say. Yeah, so acknowledging that in those relationships, because there have been many times where in history where well-intended things have come into communities and had disastrous impacts. So I think it's worth acknowledging that as we think about that trust building.
And just a follow-up question. In Ontario, as well as in other parts of Canada, there is a requirement to collect data on populations and put it into centralized, often provincial databases. What impact is that having on the collection of data of Indigenous peoples? And for those of you who also collect data, this also might apply to racialized communities. And I'm wondering if you can speak to the collection of data and its challenges and its importances.
Yeah, so it's very important that the people who need the data have the data. And the people who need Indigenous data are Indigenous leadership and Indigenous organizations. So when that data is already flowing, then, even from as long, there may be a perceived data gap if it's not going back to provincial governments or something like that. But from the First Nations, Métis or Inuit perspective, it may not be a data gap. So I think perspective is really important when we think about that. And with it, and there, especially early in the pandemic, there were a lot of conversations about the need to have Indigenous identifiers in the data. And without the strong relationships and already established governance of data, it's really hard to impose that in a pandemic, because that sovereignty and the data collected, the governance of that data collected is very important. And so that trust building around collecting of data and use of data has to be built over time. So I'm grateful that we were able to build that over 10 years with Chiefs of Ontario and 10 years with the Métis Nation of Ontario so that we could get data out quickly. But where we were sort of saying, oh, okay, well, for the first time, we're going to start collecting Indigenous identity in Toronto, that's a hard time to start saying we're going to start collecting information about you, right? So it's that longer term trust building that needs to be there. In the middle of a pandemic, it's really hard.
Thank you. Important issue. Andrea, you're shaking your head. Would you like to comment? You can comment from Indigenous or other racialized communities on the collection of data.
There we go. Sure. I can just comment and say that to Jennifer's point, I think those relationships are key. And from a CIHI perspective, First Nations, Indigenous, and Métis was actually a strategic priority population in our last strategic plan. And we recognized fairly early on that that 5-year window was not going to be a realistic opportunity to sort of build those relationships and have that sort of established trust to work forward. There are some data sets at CIHI that have Indigenous identifiers, and we don't use that information. It's something that we'll continue to sort of build as we build relationships and start to work with data. I completely agree that the people who need that data is that leadership at the Indigenous level. There's other types of data and there's other types of information that are, sensitive. So things like our equity stratification toolkit, things like some of the geographic indicators that might indicate that somebody lives on a reserve or somebody lives in a lower socioeconomic status neighborhood. Those are also the kinds of data sensitivity issues that we're really trying to sort of build into our standardized work across our data sets.
Any other speakers wish to comment on this topic? Right, we're going to move on then, and my next question is for you, Dr. McAiney. Older adults were clearly disproportionately affected by the COVID-19 across the world. And if you look at this from a post-pandemic perspective, what are the changes we need to bring to make our communities age-friendly and more specifically dementia-friendly?
Great. Yeah, it's hard to sometimes think about post-pandemic right now. So just to give a little bit of an explanation of age dementia friendly, those are communities where we have changes both in terms of the physical environments and the social environments that really allow full participation of older adults or people living with dementia in our communities. So making sure that they're comfortable and they're feeling safe and they have opportunities to engage in meaningful activities as well as in decisions. So that's something that many groups are really trying to work towards, to have both age and dementia-friendly communities. Because in many ways, if we have those, then that's a good thing for everyone. So a key piece of this would be education and the need for education around not only older adults, but dementia specifically. There's other speakers have talked about the issue of stigma. So there's a significant amount of stigma when it comes to dementia and a lack of understanding and often a lot of fear around dementia conditions. So how do we start to, build awareness and understanding of dementia and that it's not, a homogeneous group, that there's a lot of variability there, and to understand what the dementia means, what the progression looks like, and how do we, I guess, celebrate and provide opportunities for people to contribute along the way, along their journeys, because a lot of times a person will go in to get a diagnosis, they'll go in to see their doctor, and they have all of these abilities and rights, and then they walk out of the door with that diagnosis, and all of a sudden it's like all of those rights and abilities have gone away, and that's just not how it works. So we need a lot more education, and I think we need to engage people living with dementia about how best to do this and to help us understand how we learn from this pandemic and make our communities and our broader societies more inclusive and welcoming for our older adults and for those with dementia.
Thank you. Thank you very much. Anybody else want to comment? My next question is for Dr. Goel. The pandemic was the worst case scenario for long-term care homes, obviously, with very high mortality and morbidity, including significant mental health impacts for residents and families. Can you speak to what will need to change in foundational health policy principles to prevent such occurrences from happening again? Your slide deck did sort of hint at this, but I'm just wondering if you had to center in on a few key things as to what might prevent this from happening again, and then there's a follow-up question to that. What measurables would you see as useful if you were advising governments to track a future risk? So.
Right. So it's a very easy question. Thanks. I think as I referred to, the reports are there on what we need to do for long-term care, and Veronique went over some of those recommendations. And every area that you can look at, we've got reports on Indigenous populations and what we should be doing. We've got reports on public health and how it can be improved. And I'm also chairing a group right now to developing a long-term health data strategy. And we started by going through 60 years of recommendations from different reports on what Canada needs to do. So, my first point is that we don't have a shortage of the knowledge or the actions we need to take. And we need to really think about what have been the barriers to implementation. And on this specific issue, I think we have to start with the need for political will and the willingness to make the investments. As we're speaking, the Ontario budget's coming down. We'll see, what have they learned? What are they putting in this next year? But, the reality is at the polls, when politicians go door knocking, the health issues that they hear about the most are acute care, right? Why can't I get my knee replacement? Or why is the waiting time for cancer surgery so long? And issues of investments in community care, long-term care, public health, very rarely, and I remember asking a Minister of Health once, who was very supportive of public health, why don't you do more for this? And she says, well, the reality is when I go knocking on the door, nobody asks me for investments in long-term care or public health. So for me, it's got to start with education. We got to work harder to have the population understand the importance of these issues. And COVID-19 has laid this in front of people, and now they're asking these questions. They're being asked in the media. Because in the end, in a democracy, we elect the governments and they respond to what voters will say. So there's not a simple fix, because if it was simple, it would have been done. But it has to start with a political willingness to actually act on what's already known. And then the other part of this, and I think it's already been referred to, is we really need to look at aging from a holistic perspective. And so again, in governments, they tend to look for quick fixes. Okay, we're going to work on long-term care. We're going to reform home care again. And every 5-10 years, we'll do a fix in a particular area, as opposed to saying, okay, what do we really need to do to ensure that people can age in as healthy a manner as possible. And it's not necessarily going to be about any one sector. It's going to be about how you get everyone to work together. And I would say in Ontario in particular, we've been particularly challenged with trying to bring things together. I'll just go back, and you may also remember this. Like, there was a time when public health was responsible for home care. And in many parts of the province, the public health, the medical officer of health was also responsible for the homes for the aged in the region. And that actually brought things together in a way that is now completely siloed. So how do we get back to some of those more horizontal ways of doing things? Would be a few of my thoughts.
And if you were to advise government, what measurables would you suggest that they track to see how they make progress on right now?
So, again, there's lots of indicators, and CIHI puts out lots of indicators in terms of health outcomes. The first thing I would actually say is we need to start to focus on tracking measures of population health status, and we can do that by age group. And so right now, we tend to again focus on what I would frame as inputs to health status. So how many hospitalizations there were, how many doctor's visits, and so on, and to really shift to measures of population health, and to fund and to hold health system, not just public health, not just long-term care, but the health system as a whole, accountable for those measures of population health.
Well, that definitely resonates with me, so I support those comments. Anybody else on our panelists would like to comment on this topic? All right. Oh, sure.
Sorry.
No, go ahead, please.
You just prompted me to think about the importance of measuring wellness and not just counting deficits all the time and disparities. And so I just want to contribute that sometimes we, particularly as we're working with Indigenous communities on what outcomes indicate wellness or community health or population health, sometimes those things might be different than just, okay, let's see if we have less or more diabetes than the neighboring communities. It may be different kinds of outcomes, and the data we collect leads us to measuring deficits. So it's all the way from deciding, what counts to collect that we need to kind of shift our thinking about.
I would agree, and although I'm the moderator, I'd also add that neighborhood design and things that are far outside of health, a number of parks or areas, I think the pandemic has also brought some of this to light in terms of places where people can go, and many of the things that we should measure are not within healthcare, as we all know, and that's very difficult for sometimes our politicians to align the two together. But thank you for those comments, Dr. Gwell and Dr. Walker. For you, Dr. Boscart, so I found your talk very very interesting. There's a lot of slides at the end that you weren't able to quite get to. So the question is, prior to the pandemic, the importance of personal support workers, or we would call them PSWs in Canada or Ontario, as one of the key employee groups in our long-term care homes was not known to the general public. I suspect many people didn't even know that term, PSW. They make up a high proportion of the staff being employed at long-term care homes. But PSWs have a high turnover rate, which you had mentioned may be now as high as 60%, but it certainly was 40% prior to the pandemic, with them leaving prior to graduation. So how do we work towards building systems that employ and retain PSWs? And I'm wondering if you could speak about it from the employer side as well as the employee side, and things that might be outside of monetary as well.
Yeah, thank you, Dr. Mercer. Very, very important question. And PSWs are really that backbone of long-term care and retirement living, but they are often what we call the unseen workforce. because they do not document care, and they are not always recognized or therefore valued for the work that they do. And so a big secret to success, if I may say so, is to make sure that they are recognized as a very important part of that care team, and they belong to teams, and they receive the support and the recognition that they deserve. Support and recognition can be financially, ought to be financially, and there is some measures that we need to put in place for that. Having minimum wage at least is a requirement. Having paid sick time, not having to run from one shift to another in order to meet ends would be one step forward. The second component is that this group is often overlooked when we talk about additional training, onboarding, recognition, and rewards when they are in the job for 6 months, 5 years, 10 years. And so from a successful team approach, there is lots that can happen at a home or retirement home level to really keep people on board. And then another component that has proven to be successful is promoting within. So providing those opportunities for PSWs to not see their role as a job, but as a career opportunity within a home or a village would be an important recruitment and retention marker, and is not always tapped into. So it starts really with the education. I think nurses or physicians don't really understand what a PSW does, and therefore do not always value it. So role recognition starts from day one in the schooling, and then it needs to carry forward throughout the career itself. And so those would be some of the suggestions I would have to retain PSWs in the workforce.
As somebody who started off my career as a PSW many years ago, I recognize it's a very, very challenging job to do. Dr. McAiney, I wonder if you would like to comment as somebody. I know you're with Schlegel Villages, so.
Yeah, no, I completely agree with Dr. Boscart about the value of PSWs. And, I think one of the other issues that kind of comes into play is that, a lot of individuals that are working in that role are from more marginalized populations. And I think that the level of education, the different ethnic and cultural backgrounds, I think contributes to some of the stigma against those groups. And I think that those are other issues that we need to think about and try to address. And I think some of the suggestions that Dr. Boscart has put forward, especially in terms of valuing that role, they're the ones that spend the vast majority of time with the residents. They're going to be able to pick up on little changes that happened and be able to alert people like physicians or nurses earlier and to hopefully prevent further decline. So I think it's a real shift in the way that we think about that role, and to really try to promote their skills and abilities and to address the stigma that might be there.
Anybody else wish to comment?
Just to add that, again, the pandemic has shown how important different roles in society are that we haven't traditionally valued. And so if we think of, the workers in long-term care tend to come from immigrant populations, where if you put long-term care aside, where have been the other major outbreaks, meatpacking plants, supply chain, warehouses, the foreign agriculture workers, it's all the same populations, and it's all environments where we haven't traditionally valued the work, but it's turned out to be the work that was most essential for keeping us going, and particularly those of us who were able to work from home throughout the pandemic. And so again, the big lesson is we really need to think about how we value different types of work and reimburse people, pay people for that work.
As we're drawing to the end of our question period, I'm just going to go around, and I would just like for you to come up with one thought. If you were to say to your future self in 10 years, what is the one thing that we hope that we will retain with us and that will change us and create this path forward for us as a future as this pandemic, because it's changed all of us, it's affected all of us, but as researchers, as academics, as clinicians or physicians, well, what are we taking with us as we move out of this pandemic? And I'll start with Dr. McAiney.
Great. I guess the one thing, and I don't know if it's completely answering your question, but it speaks to what Dr. Boscart and Dr. Goel spoke to before. A lot of the ways to make improvements and to learn from this experience, we know already. We've got a lot of recommendations and so on to build from. And I think the fear is that once again, nothing's going to happen. And so hopefully we will learn from our mistakes of not doing things before and actually put some of these changes into place to make things better for everyone.
Thank you. Dr. Fobel?
Thank you. And I agree with what Dr. McKinney said. And it's, there's been a lot of nuggets of this throughout the panel, I think. I think if I think of, the opportunity that comes out of a situation like the one we're in, is that, it's really highlighted where are there gaps in workforce, but where does that feed down into the kind of data we're collecting? Even the timeliness of that data, I think CIHI as an organization has had a lot of thoughts around what's our role in, putting that provisional or open data out there. So I don't think there's going to be a going back point. So I think looking forward, it's really making sure that we get that flow in a way that makes sense to inform and continue to inform the healthcare of Canadians.
Thank you. Dr. Walker, your comments.
One of the things we're trained to do as Indigenous health researchers is to work in relational accountability. So this accountability to community, to ourselves, to our families, but also to the earth and to water and to all of our relations. And I think that actually one of the things that I'm coming away with is a greater understanding of that. And the work that we've continued to do with elders and knowledge holders throughout the pandemic, they've tried to make sure we understand that this pandemic has been trying to tell us something, that we need to listen to it, and that, like maybe there's things that I'll change about the way I interact with the world, how often I fly, how often, all those things, right? Like just that we can come together for complex challenges like global climate change, like global pandemics. So I think that sort of more holistic awareness of our accountabilities to each other and to the earth are things I will take away.
Thank you. And Dr. Boscart.
That's difficult to follow, Jen. But building on that, I think the one thing that I have taken away is that the need for me to be even more persistent on developing the next generation of leaders to provide the most hands-on, relational, supportive, and person-centered care to the people that unfortunately are in long-term care, believing that we can do a great job if we can honor those people. And so from an educational perspective, I think we just need to really get those people out there so they will do a great job once we retire.
Very hopeful. Thank you. And the final word, Dr. Gwell.
So this will be a variant on the last theme. I think it's also just the broader education of everyone in society. And I think the challenges we've faced have shown the importance of literacy, data literacy, the ability to consume social media wisely. And so really thinking about what in our educational programs for everyone, K to 12, college, university, we include so that they can be partners with us when we have these kinds of situations.
Well, thank you. And I wish to thank all of the panelists for this session too, on the first day. And now I believe I get to turn it over to Paul Stoley for the final marks.
Thank you very much, Dr. Mercer. As Dr. Mercer said, I'm Paul Stoley, and I'm the director of the Network for Aging Research at the University of Waterloo. I'd like to add my very real thanks to this afternoon's virtual Hallman panelists and moderators for 2 informative and thought-provoking sessions. And to all of you who attended today's sessions, please stay for the poster session to follow. For those attending today, there are a couple of upcoming events you may be interested in. First, please put a pencil mark in your calendar for the afternoon of May 29th, 2021 for the next Hallman panel event. This is still tentative, but if you found today's sessions interesting, you won't want to miss this. Secondly, the 50th annual Canadian Association on Gerontology conference, and I'm looking at that association's president, Dr. Boscart. This conference is scheduled for October 21st and 23rd in Toronto. It sounds like this is actually going to be a real conference in a real place. The theme this year highlights Hindsight 2020, looking back for a vision forward in gerontology. The call for abstracts is now open and conference registration will open this summer. This conference event continues tomorrow, Thursday, on the theme of implementing and adopting aging-related technology. Opening remarks begin at 1 p.m. Eastern Daylight Time. The keynote speaker for the William F. Forbes lecture is Dr. Neil Charnas from Florida State University. His theme is the promise and limits of technology to promote successful longevity. The William Forbes Lecture is held in memory of the founder of the gerontology program at Waterloo, and we are very pleased to have Dr. Charnas for this event as a leading international scholar in aging and technology and a former colleague of Professor Forbes. This will be followed by 2 panel sessions hosted by the Center for Bioengineering and Biotechnology. The first one's theme is technology to promote successful longevity and strategies for adoption, to be followed by innovative models of care for older adults. Following the closing of tomorrow's events, there will be an open networking sessions with researchers and conference attendees. Once again, thank you all for attending today's session, and please stay for the 30-minute poster sessions on research on aging starting shortly. University of Waterloo researchers and students will be live in their rooms to answer your questions, accessible from the Connect menu on the left of your screen. So thanks again, everyone. Bye for now, and we'll see you soon.